Hello, my name is Aytekin Oto. I'm the professor and chair of radiology at the University of Chicago. Today, I'm going to talk to you about our experience at University of Chicago on MR-guided laser ablation. We're one of the pioneers of this procedure. I will also provide you a quick update on the current long-term performance of FLA, challenges facing FLA, and we're going to finish up with a few suggestions about the future of focal laser ablation. So as this group very well knows, focal therapy is a very optimal middle ground solution for localized prostate cancer, anywhere between prostatectomy all the way to active surveillance. So the advantage of focal therapy is it balances oncologic efficacy and safety. So it allows eradication of the target for effective cancer control while sparing the organs at risk, and also it doesn't burn any bridges. You can always retreat if needed with either focal or whole gland therapy. This is the laser device that we use. There are a couple others out there now. This was one of the initial laser devices. So you can essentially connect this to any MR scanners. Here's a laser fiber, interstitial fiber that's inserted into the prostate where the target is. And this procedure can be performed either transperineally or transrectally. So in our institution, we mostly do transperineal ablations. This is the perineal template that we use for localization. So after placing the template in patient's perineum, the second step is registering the template into MR images, and then you find the target, and the software tells you which hole of this template you put the needle and the depth of insertion. And once you put the needle in place, you can always check after a quick MR scan, make sure that the needle is in place. And then next step is to do real-time MR thermography and real-time damage estimate, which is, I think, the main advantage of this particular MR guidance for laser ablation. And you know exactly where your needle is, where you're going to ablate, and maybe more importantly, you know where exactly you're not going to burn. And once you do your test dose, you can then turn the laser on for a full dose ablation. And here are some images. Here's the post-ablation, post-contrast. Immediately, you know the area of coverage, so that nicely covers the area of cancer. So that gives you a good sense of success of the procedure. So when we started, 8 years ago, or maybe 10 years ago, actually, the first case, so we did a phase 1 trial. We included 9 patients, and the primary endpoint was safety and toxicity, and there were no serious complications, no change in urinary and sexual functionality. So concluding that this is a safe and feasible procedure, we moved on to a phase 2 study where we recruited 27 patients, and we followed them for 1 year. So 1 out of 27 patients had Gleason 6 cancer on 3-month MR-guided biopsy, and 3 out of 27 had cancer on 12-month on TRUST-guided biopsy in the ablation zone. 6 patients has new Gleason 6s, and 1 patient had new Gleason 7 cancer focused elsewhere in the prostate. Here's a case with cancer in the right middle lobe. This is the immediate post-ablation images. Here you can see the needle in place. These are immediate post-ablation images, and then 12 months later, you can see a cyst replacing the site of the cancer, which essentially cured this patient from disease. Here's another patient with cancer in the left mid-peripheral zone. This is immediate post-ablation scan, and then there's 3 months, and which shows no cancer, and then 12 months after a year after the MRI also showed no cancer at the site. And 12-month safety profile was also very promising. And based on this, we actually started offering this procedure as standard of care in our institution. One of the challenges that we faced was to understand the area of ablation during the procedure without giving contrast. And we looked into the role of the T2 star, and actually T2 star imaging seems like a good and reliable sequence to have some idea about the ablation zone during the procedure. Here are 2 papers with a relatively small series, but with one 5-year follow-up and the other one's 3-year follow-up. So essentially, they both concluded that there's a high rate of failure-free survival, but in-field local recurrence rate is high in both of them. I think that's one of the main limitations of focal laser ablation, but also some for other focal therapies as well. So currently, MR-guided FTA is a clinically offered procedure in about 5 centers in North America. Most of them do transrectal approach. Very few does transperineal approach, and sometimes reimbursed by the insurance. We also hear a lot about truss-guided laser ablation as an office procedure. And prostate FLA is dropping off of Medtronic's MAP. But then as a reaction to this, some other laser companies are actually picking up. And ultrasound-guided procedures, either FLA or other competing options, are certainly important to keep in mind in this lane. The challenges in focal therapy are lesion mapping, in-procedure monitoring and planning, and identifying local recurrence, or actually the fact that there is high local recurrence, as we talked about, and then the competing focal therapy methods as competitors in this field. So I think first off, to start, for patient selection, we need to, we all agree that the goal here is to replace aggressive surgery or radiation, but not active surveillance. One of the limitations of MRI is underestimating the volume of cancer. This is true for all three sequences, T2, DWI, and DCE, but DCE seems to be the best indicator for prostate volume. So I think if someone is planning for FLA, dynamic contrast enhanced early DCE MR images are really important for planning purposes. And of course, I think the future is on quantitative MRI, either using AI or not using AI. So this is hybrid multidimensional MRI is a solution, quantitative solution that we came up with. So essentially this novel MR acquisition and interpretation tool gives automated quantitative estimate of percentage of stroma, epithelium, and lumen in the prostate. And based on that, we can predict the cancer. We are now almost completing our single center prospective trial that patients come in for biopsy, and before biopsy, they get the routine MRI, and our predicted cancer map picks the target, and these targets are biopsy together with pyrite space targets, as well as the regular truss-guided. Well, of course, in this patient, you can see a clear target on our tool that's also agreed by the radiologist. Here's another tool. In this case, our tool, HMMRI, identified this lesion in the right middle zone, which was not mentioned in the radiology report. So as you see, it's very difficult to pick this lesion. So hybrid MRI has the potential to show these even undetected cancers in the body, in the prostate. So these kind of tools will be really critical for the success of any kind of focal therapy option. So this is an interim summary, and hybrid MRI seems to be detecting clinically significant cancers, and detection rate actually better than multiparametric MRI on per patient and segment analysis. So in terms of future considerations, we still need to do validation for oncologic safety and efficacy, and we need to address the local recurrence issue. That's really important. We have to definitely keep a close eye on the competition, both for ultrasound-guided FLA as well as other focal therapy methods. Reimbursement is spotty, so that remains to be a problem. And then still we need some well-established follow-up techniques or follow-up guidelines for after focal therapy. So in conclusion, MRI-guided FLA is a safe and feasible treatment method. Local recurrence and long-term follow-up needs to be addressed. Imaging is the centerpiece for focal therapy, for identifying the right patient, for planning, for accurate planning. Certainly quantitative MR techniques, we'll hear more about them in the future. They can address this limitation. There are other competing methods that we should be aware of, and for probably it's true for most procedures today in or complex procedures in today's healthcare landscape, but multi-specialty coordination and collaboration is definitely critical between the urologist and oncologist and pathologist. Thank you for your attention.